Good afternoon and welcome. My name's Eugene Lugg and I'm the Victorian Hospital Engagement Coordinator for the National Heart Foundation. I'd like to welcome you here today for this webcast on the cardiac blues and depression post-heart event. This webcast is a collaboration between the Heart Foundation and the Australian Centre for Heart Health. It's proudly funded by Safer Care Victoria. So welcome, and I'd like to introduce our expert panel. To my left we have Dr. Barbara Murphy. Barbara Murphy is the Deputy Director of the Australian Centre for Heart Health, and she has over 20 years of experience in research and program development to support patients' psychosocial recovery after a heart event, focusing mostly around the cardiac blues and depression. Welcome, Barbara.
Thanks, Eugene.
Next we have Rosemary Higgins. Rosemary is a cardiac health psychologist and an academic specialising in helping heart patients live better. Dr. Higgins is a clinical consultant with the Australian Centre for Heart Health and has multiple academic appointments also. Thank you, Rosemary, for joining us. Next, we have Neve. Neve Dormer is a cardiac rehabilitation coordinator at Cabrini Health in Melbourne and has extensive experience in supporting heart patients after their hospital experience to return to their version of a quality of life. Welcome, Neve.
Thank you.
And last but not least, we have Kym Tucker. Kym is a clinical nurse specialist at Monash Health here in Melbourne and leads a team at Monash delivering inpatient bedside education, referral and support for patients who have experienced a heart attack or heart surgery. So welcome to the panel.
Thank you.
So just before we start, I'd like to remind viewers that there's a Ask a Question tab at the bottom right-hand side of the screen, and please feel free to ask questions over the duration of the webcast today. And it's important that we acknowledge that we're broadcasting across many traditional lands today. We pay our respects to our traditional owners of these lands and to elders past, present and emerging. So let's get started. Treatment for heart attacks and heart surgery outcomes have never been better, with patients treated faster and better access to evidence-based therapy. However, many patients leave hospital feeling that they are fixed, and many healthcare providers are unaware of the struggles that patients face on their return to a quality of life after a heart event. Today we'll be exploring the psychological and emotional experience of patients who have experienced a heart event, and I'd like to hand over to Barbara to tell us what is the cardiac blues, when we should worry about it, when it's a problem, and what we need to know about depression and screening after a heart event. Over to you, Barbara.
Thank you, Eugene. Okay, so I'm really going to be talking about the research side of things, whereas most of the panel are practitioners mostly, although they've been involved in research too. But what I'm wanting to bring is the research evidence that's behind what we're talking about today, which is cardiac blues and depression amongst our heart patients or amongst people who have an acute cardiac event. Now, there's very strong and convincing evidence now that depression is in and of itself a risk factor for the development of cardiovascular disease in the order of traditional physiological risk factors now. And this research started a good 2 decades ago, all the research around psychocardiology. And we used to rely on just a single study here and there, but now we don't need to do that. We rely on major meta-analyses. So we have a real great strength of evidence here behind this research. So we already know that depression is a risk factor for heart disease. So it's not surprising that we see a fair bit of depression after a heart attack as well. So we're mostly focusing today on depression and the cardiac blues after a heart event. So as you can see on the slide, we see about 5% of people in the community at any one time have major depression, whereas around the time of the cardiac event in hospital, we see 4 times that. So we have about 1 in 5 of people who have had an acute cardiac event, whether it's surgery or a heart attack, will have major depression at the time of the event. And this is very problematic, and I'll go on to talk about why. But not only that, we know that almost all patients, a good 75% or more, have what is now known as the cardiac blues. And this is very heightened depressive and anxiety symptoms felt in hospital. A reason for this is that the heart event is a traumatic event. And we know that now. It used to be that trauma was very defined in certain areas, but now we know the heart event is one of those traumatic events, and people go on an emotional roller coaster with a whole range of emotions. But one of the messages that I want to deliver is that cardiac blues isn't necessarily a bad thing. Cardiac blues doesn't discriminate. Almost anyone can get it. It doesn't matter whether you're male or female, young or old, which type of cardiac event you've had. Whereas depression has its risk factors, and we know what they are. So I'll talk a little bit now about depression. So I'm not talking about the cardiac blues here, this is depression. Depression that about 1 in 5 patients will have. Why is it a problem? Well, it's a problem firstly because it really undermines people's quality of life, and it's a very difficult thing to deal with. But not only that, people who are depressed are less likely to be able to make lifestyle changes that are needed after a heart event. They're more likely to smoke, much higher rates of smoking. They're more likely to be sedentary, less able to engage in regular physical activity. They're less able to take their medications as prescribed, much less likely to attend cardiac rehab for a whole range of reasons. Depression really undermines the will, so it's very hard to actually do the things that are good for you. Moreover, we see that people with depression are more likely to be readmitted to hospital. They're more likely to have another event. And unfortunately, there's been more and more evidence to show now that they're more likely to die early after their cardiac event. And that's in studies that control for a whole range of other physiological and biological risk factors. So that's why depression's a problem. The cardiac blues, however, is like any other grief response. It's like any other response to a traumatic event. So what we see is that the people with the cardiac blues often have very heightened, say, scores on a questionnaire, a depression questionnaire in hospital, but it will resolve in time with support and acknowledgement and reassurance. But the difficulty is that early on, around the time of the cardiac event, depression and the cardiac blues look very similar. So I'll just take a moment to talk about 2 of the ways that we can help to identify whether someone's going through the cardiac blues, which we can then normalise and reassure, or whether someone's likely to go on and become depressed. So the graph that you can see on the screen there, it's showing scores on a depression scale. It doesn't matter what that scale is for the purposes of the argument, from in hospital to about 2 months at the little mark and then 6 months. So we can see that people can take a range of trajectories. The pink line shows people with very heightened scores in hospital and they resolve. And that's really what we would call the cardiac blues. That's not associated with a poor prognosis. In fact, in some of our studies, we find that the people who've got some heightened scores in hospital actually are better off later on. The ones we really worry about are the yellow line there, and I hope people can see it on the screen. They're the ones who don't score very high in hospital, but they go on to show depression further down the track. So they're the ones at risk of going under the radar or falling through the cracks, or however you'd like to call it. Obviously, the aqua line up the top, we're going to catch those people somewhere along the line because they're going to continue to screen high or score high. It's that yellow group that have the very poorest outcomes. And the way we can identify them relatively early on is by what we call red flags, the most important of which is having had depression in the past. People who have had depression in the past will be up to 4 times more likely to have depression after their cardiac event. In fact, a recent study suggests that it can be as high as up to 9 times. And then our other red flags are things like social isolation, smoking, being that little bit younger at the time of the first event, having other comorbid conditions like diabetes, obviously financial strain is just adding to the stress, and if there's a compounded loss like a recent other bereavement, a death of a loved one or so on, people might be more at risk of not being able to get through that normal grief process. So that just really now summarises what I've just talked about, this little table here, where our cardiac blues people, we want to be normalising, reassuring. People who we're concerned about depression, they're the ones who we really need to be making sure we identify and appropriately manage and refer.
Okay, so the cardiac blues and depression are different.
Correct.
And the cardiac blues is almost a normal coping mechanism to a shock event. Is that the message?
I think that is the message, yeah. If we can like it to any other grief response, any other traumatic event, and with any grief, we give people time to get through that process. We reassure them, we normalise it, we get them supports, we help them through. A lot of people after their heart event, that's what they need, and we definitely don't want to be pathologising something that's a normal process. So we'll talk about screening further on, but...
And you mentioned, Bob, gender-based differences. We're not seeing any male or gender biases in any of the sort of studies that have been done?
Not with the cardiac blues. Obviously, we do see higher rates of depression amongst women in our cardiac patients, but we see higher rates of depression amongst women more generally. And as Rose put it very nicely the other day, it's because we see higher rates of help seeking amongst women. So not necessarily that women are more depressed, but they will seek help and therefore get counted. And men are a little bit less likely to come forward with their emotional symptoms.
Okay, fascinating. Rosemary, can you give us some insight into what you see when cardiac patients come to see you as a health psychologist? What sort of challenges do cardiac patients go through after their heart event?
Well, it'll be different at different times of their trajectory. In the early days, they can be quite hypervigilant. They'll have a heightened sense of anxiety, will have lost trust in their body, will be scanning for the possibility of further symptoms or, trying to understand any physical sensation. Many of them will be very aware of their mortality, they see a heart event as a life-threatening experience, regardless of whether or not it was actually life-threatening. So it's generally seen that way. So they might have existential issues around, and they will have grief and loss issues. They lose role, they're challenged with their loss of the illusion of mortality, loss of that belief in ongoing good health. They'll have to make changes quite often. They'll be told by many people, so there'll be a challenge to their autonomy. They've lived their life how they wanted to live, and now lots of people have lots of opinions on how they should live their life. And that can be quite challenging. They can feel quite guilty if they've felt like they've abused their body. They may feel guilty, or they may feel angry or ashamed. And it's tricky because it can happen so quickly for people. They may not be prepared. They haven't thought this through. You don't get practice in having a cardiac event mostly.
In your practice, do you find that people who have, maybe this is their first real health diagnosis, their heart event, that they're more likely to struggle?
The first time that people get this awareness of their mortality, whether they get it at 20, 40, 70, 80, it seems to be quite a major thing for them to go through. That they'll say to me, I thought I was Superman. I thought I was invincible. I thought I was unstoppable. I never imagined this could happen to me. So yeah, it is, for them, it's quite an adjustment. And the grief is that loss of the illusion of immortality, I see.
Thank you, Rosemary. Kym, you work in the inpatient environment, so you see patients acutely after their heart event or after their heart surgery. What sort of emotional and psychological features and experiences do you witness in the inpatient setting?
Well, when patients are admitted to hospital, They're often in a lot of pain and very scared. And we as clinicians see a whole range of different responses when people are in hospital, and they vary tremendously throughout their stay. We see people that are very tearful, they're very frightened, they could be really angry or irritable, or they could be nonchalant and putting on a brave face, whereas underneath all of that, they do report being overwhelmed. Most patients do report being overwhelmed, and also they receive a lot of information while they're in hospital. Being in hospital is really unexpected. When that patients got up that morning, they got about their business, they went to work. It's the last thing they expected was to be in hospital. And they're thinking they're going to die, they're having thoughts of dying. Clinicians in hospital are very skilled at reassuring patients at this stage. Patients are very concerned, they're very anxious, and they're getting a lot of information overload. They're getting information about what's happening to them, the procedures, the medications they're going through, their changing condition, lots of people attending them and lots of information. It's a very busy place, but we must, and there's a lot of emphasis on the physical, but we must remember that there's an emotional and psychological impact that's happening. And often people are worried about, will they ever get back to normal?
Wow, fascinating. And Neve, on to you. You see patients after they've been discharged from their acute event. They've probably gone home for maybe a week or two, or maybe a bit longer, and then they come back to you in the cardiac rehabilitation setting. What sort of psychological and emotional experiences do patients report when you see them?
So we often see patients in cardiac rehab who are going through cardiac blues and feeling depressed. So when they come to us in the cardiac rehab program, often they're feeling scared about returning to work, scared about exercising. A lot of the emotions that they have are overwhelming. So the shock, the anger, they feel guilty, and they tend to blame themselves. Again, they're overwhelmed with emotion. Sometimes they can be withdrawn as well, and tearful. Certainly we would see people who suddenly become quite tearful. And that brings to mind an example. Last week in our practice, a patient came in for an assessment, and it was the first assessment, and came in and sat down. And my first comment was, "Oh, how have you been since you went home?" And the patient became tearful and just said, "What have I done wrong?" So that was the question. So a lot of the questions we'd get is, am I not coping? Is it just me? Is this normal? They're feeling quite overwhelmed. And on top of that as well, fatigue and tiredness is quite strong with a lot of people. So they're trying to get back to their normal activities. They're feeling tired, not maybe disturbance in their sleep pattern. So they're quite vulnerable at this stage when they come to us. And again, quite a bit of hypervigilance with every ache and pain. So there's been quite a lot of change has happened. Change to their self-identity, change in their role, so maybe a sick role, taking medications they weren't taking before, lots of medical appointments. So increased support on their family, carers, or people that they're relying on to help them. So with all this change that occurs with a cardiac event, it's often quite sudden, and it's the suddenness that we need to be aware as clinicians that it takes time for patients to adjust to this and to normalise it when we see them, so that these strong emotions are quite a normal thing that people go through. But it's a whole range, of they're quite frightened, a lot of patients. Yeah.
Do you feel like Kym talked a little bit about how busy the inpatient environment is? Beeping machines and ventilators, or ECG monitors. And do you think that when patients get home and then have to really I guess it's all quiet and they get back to their normal lives, that's when things tend to hit them. Is that what you see?
So yes, it can take a while for someone to come to terms with the diagnosis and what's happened them. And so when they come to us, they may have a lot of questions around, what exactly is involved in their recovery. As well as that, I suppose we have the opportunity in the outpatients to develop that relationship with them, because they'll be coming in frequently to attend classes. We can build that relationship and that rapport in a trusting and safe environment, and we can get to know them, check in with them regularly while they're coming in. How are you feeling today? And listening, asking the question, how are you feeling, and listening to when they reply, and being compassionate, having empathy, and really listening to what they're saying. Yes.
Rosemary, do they talk to you about that first night after they go home from the acute episode?
Yep, their night of terror.
Yeah.
And the partners talk about it too, because they'll say, they were sleeping, but I kept an ear out and I was wondering if he'd stop breathing or she'd stop breathing. And so there's all of that as well, that heightened anxiety and that insecurity and really not knowing what the future holds.
Okay.
And I think the research evidence points to the importance of that period when people go home as well, because when you take into account some of the red flags that we looked at, living alone and social isolation, smoking, having comorbid conditions, having financial strain, they're all some of the things that make it much harder to adjust. If you're going home to a partner who's supportive, perhaps a family, extended family who's supportive, perhaps a workplace who is going to welcome you back and help modify your job while you're at it, it's going to make that transition somewhat easier. If you've got a whole bunch of risk factors that are going to make that adjustment more difficult, that's where that depression can hit in. And importantly, they're the ones who are going to be least likely to come and see Neve. They're going to be least likely to get to cardiac rehab. Only 1 in 3 patients leave someone like Kym and get to someone like Neve.
Yeah.
And the other 2 are going to be much more likely to be the ones who are depressed or have other difficulties.
Yeah.
So it's really important that we do encourage everyone to get to cardiac rehab.
Yeah.
And by having that conversation around the cardiac blues and depression early on, it helps to make patients aware of it when these emotions do come up, that it's okay to act. It's okay to ask for help. These are normal things. I don't need to run and hide, and I'm not the only one going through it.
Yeah. Okay, thank you everyone for providing your insight from your respective settings. We might move on to a case study just to highlight some of the issues we'd like to discuss. So I just wanted to introduce Sam. So Sam's a 54-year-old who's been admitted to hospital after a heart attack. Sam works as a self-employed software designer and is recently separated from his wife. He lives alone, but he does have adult children. He has had a history of depression in the past, and in hospital he's showing no depressive symptoms. So Barbara, what would you be concerned about? What sort of red flags would you think about when you look at that case study of Sam?
I guess Sam is a classic one of those ones who might follow the yellow line that we had showing before. He's not showing any depression signs in hospital. He might, if we did a screen in hospital, he might not score very high at all. His biggest red flag to me would be the fact that he's had some depression in the past, and it might not even be on his chart. You might need to ask that. He might need to disclose that, so that requires some sort of conversation, obviously. He's living alone, and that's another challenge, because he's going to be less likely to have the partner that Rosemary was talking about, who helps share the load and check on him when he's not not breathing or so on.
Who's and scared enough to worry whether or not he's breathing.
Exactly. He might be less likely to look after himself as well because of that. Being self-employed could be a little bit of a red flag because he's not going to have someone, he's going to want to perhaps rush back to work because of financial strain, perhaps. We'll need to ask more about that. And he's also possibly had a recent bereavement or compounded loss through the separation with his wife. I suppose we'd need to find out a little bit more about what that meant for him and what impact that's had for him. So he's definitely got a few red flags there that we'd be feeling concerned about.
Yeah.
Yep.
And so I want to go over to Kym and ask her about how she would manage Sam in the inpatient environment. But before I do, Barb, there's a question from the audience, and Joshua, who's an exercise physiologist, has just asked, which validated tool would you recommend to be used in inpatient screening for depression?
Okay, that's a good question, Joshua. And of course we would refer to the consensus statement from the Heart Foundation and the Cardiac Society of Australia and New Zealand. So that came out in 2013. The recommended tool is the PHQ, the Patient Health Questionnaire. It begins with 2 items, so the PHQ2, followed, which I think we've got on the screen now, followed up by, if people score yes on either of those 2 first items, we go on and do the PHQ9, which is just 7 additional questions. And there's a scoring tool. It's in every language possible. It's free, it's downloadable, and so on. So it's been well validated with cardiac populations. There are some other tools that have been well validated, but this is what's recommended. It was originally recommended by the American Heart Association, and then the National Heart Foundation adopted that as well, given its psychometric properties and its good case-finding ability and its ease of use, really. So, Joshua, that's what we would recommend. Having said that, I think we understand that certain hospitals have different ways of doing this, and if there's a tool being used and it's difficult to change that tool, then of course you just go with whatever's being used at the moment, with a view to moving towards the PHQ when that's possible.
Great. Sorry, Kym, I'll go back to you and Sam. So I'm just interested how you'd approach Sam in the inpatient environment, what you might want to discuss with him, how you'd approach him.
Well, someone like Sam is probably the favourite sort of patient I'd have to go and speak to about what happens when he goes home in the first 2 days, the first week, and several weeks after a heart attack. And with a rapport hopefully already established, clinicians can support patients and talk about their emotions and feelings hopefully at any time. But when we're talking about something like the cardiac blues, it's ideally when the patient's pain-free. When he's pain-free, he's stabilised, he's had all his procedures, and he's been seen by his doctors. And I'd sit down and talk to him about, what happens when he goes home. But specifically, I'd start by giving Sam this pamphlet and talk about the emotional recovery, and the premise of the cardiac blues is that a heart event is an emotional experience, not just a physical one. So that's how I'd start the conversation and go through outlining maybe any feelings that he'd be having, or if he is on the scale of not having any expressing any emotions or feelings at this stage, I'd go on to say that he may experience these when he goes home, and normalise them. Talk to him, listen to where he's at, what he thinks about what's happening to him, reassure him, normalise. But I would alert him to potential risks and say to him or educate him that some people do go on to have depression if they have risks or red flags, like Barbara outlined before, but 75%, most people don't go on to have depression. So it's an education sort of discussion to have. Check with him if he has strategies to deal with any feelings that he might have when he goes home, friends, family, colleagues, local doctor, but also refer him to cardiac rehab. I think referring someone like Sam to cardiac rehab and emphasising with him the benefits, the long-term benefits from him for both physiologically and psychological recovery after a heart event is important to him. But it's at this stage that I would probably, or we would, at Monash, we do the screen for depression. And if I could talk about that at the moment.
Yeah.
So we do use the PHQ-2. It's a really simple screening. And I would say to Sam, look, we're just screening for your emotional recovery. We monitor that just like we monitor your physical recovery. And it's just the 2 quick questions and a score. And what we do is we just document that in our discharge summary. So we're basically communicating that to the health providers that he will come across at cardiac rehab, his local doctor or his cardiologist in the future.
Yeah, great. Kym, sometimes these conversations are really hard to start, you know, to talk to someone when you don't know them too well, and obviously it's a busy environment. Have you got any advice on how to sort of start the conversation with the patient around their emotional and psychological recovery?
Well, as I say, I think just the quotation of a heart event is an emotional experience, not just a physical experience, and the relief sometimes that you see in patients' eyes when you say that to them, it's a physical. It's a load off their shoulders because so much emphasis is on the physical, of course, it needs to be, but their emotional, when you connect with their emotional response and the impact that what's happening to them has an emotional impact, they're very grateful. So once you broach the topic and people are happy to start talking about it, it actually becomes easy.
Yeah. And is it my understanding that there is a body of evidence around that patients actually really want to talk about the cardiac blues and psychosocial coping? Is that right?
Yeah, there is, which is somewhat reassuring for practitioners working directly with the patients. There's some evidence to show, and we did one of the studies in this area where we asked patients 6 months after their cardiac event, did they have any discussion with any health professional around the emotional side of their recovery, and whether yes, no, and then would they like to have. 80% said they would have liked to have had a conversation with their health professional about their likely emotional recovery. So they're meaning early on, as early as possible. Yeah. They said they wanted to have a conversation and receive something really simple, which is why we went on and developed this simple pamphlet around the cardiac blues. 81% said they would have liked to have a conversation. 10% said they had actually had a conversation with a health professional during the 6 months after their cardiac event.
Wow. Okay.
Yeah, and they're not meaning, they were meaning in hospital, cardiac rehab, GP, anyone else they encountered in that time. And they said they really, really wanted to have this conversation. They said things like, if I'd known this was going to happen to me, I wouldn't have thought I was going crazy. I thought I was the only one. Yeah. I didn't know these things were normal. I thought there was something wrong with me. So just like Kym's saying, if we have those conversations, it helps to normalise it and then helps people be able to ask for help because it reduces the stigma and the shame and that sense of isolation around being the only one.
Yeah.
Can I just add there as well, during this conversation often it does create some tears. Tears come, and I think a lot of clinicians are probably worried about that. They feel that they may have caused those tears. But as we were discussing earlier, that those tears are just under the surface anyway, and it's better that they're expressed in a supported environment and normalised there. And again, the relief that patients display after having that conversation is quite rewarding, actually, after having that conversation.
And I think it probably stops them from being able to listen and learn to some of the important stuff that they have to gather in the inpatient experience if they're very absorbed by their own, individual suffering and think that this is unusual.
So do you mean like some of that other education that's provided at the bedside, like, risk factor modification, smoking cessation, exercise, that stuff might not actually get through if we don't address the emotional, psychological side of things first?
That would be my concern, because I know even myself, if I'm distressed or upset about something, I'm not very good at learning. Yeah.
I've got a lovely quote, if I may.
You may.
From a researcher, and I've mentioned it before when I've given talks. His name is Gihai, and it was from some years ago. He says, if we want people to take their cardiac medications, we need to treat their depression first. And it's the same idea that if they're sitting on emotions that are being unacknowledged and unexpressed, they can't do all the things that we want them to do that are going to help with their better management.
But it's depression that gets in the way of them doing the things they need to do rather than the cardiac blues.
True, and that quote was about depression, but then and that's what reduces adherence and lifestyle change and so on. However, even as you said, sitting on a whole lot of emotional stuff that's being unexpressed and you feels wrong or not allowed is going to inhibit how you take in information and things like that, as you pointed out. But good distinction, thank you. Yeah.
All right, great. So Barbara and Kym have both mentioned these resources. So one of them's On Track, which is a conversation tool which Barbara will discuss a bit later, as is the pamphlet, which we've got here, which will be available post-webcast. So that's a little plug. We'll move along. So Sam's discharged home after 2 days stay in hospital with 5 new tablets and an appointment to see a cardiologist in 6 weeks, which we'd probably say is pretty standard practice. After negotiating a month off his job, Sam starts cardiac rehab. Sam attends his first 3 weeks of cardiac rehabilitation, but is then absent. With encouragement, Sam comes back to rehab for his last scheduled session. He tells staff during that session that he's not been able to go back to work because he's so fatigued and he just can't get out of bed. Sam's blood pressure is high at 150/90, and Sam tells the rehab staff that he ran out of meds last week and hasn't gone to see his GP to get a new script. Sam reports that he's had some conflict with his eldest son when Sam recently missed a family celebration. So over to you, Neve. This is the time in which you would meet Sam. What would you be looking at with Sam, and what sort of factors would you address when he gets to you in cardiac rehabilitation?
So coming to the cardiac rehabilitation is the opportunity to establish that relationship with Sam and to build that trust and hoping to make it a positive experience and obviously in a safe environment. So you would obviously get to know Sam. Initially, we would conduct the PHQ-9 questionnaire and ascertain from Sam some other questions around how he's managing his mood, his sleeping pattern, his appetite, and what supports he has. So we would, talk to Sam a bit about that. Discuss how he's coping, and explaining that most people with these emotions and worries settle down in a few weeks and months, and explore how Sam feels about that and if he feels he is getting back on track with his emotions. Working with Sam, each time that he comes to the cardiac rehab, checking in how he's feeling, and important to discuss how Sam's psychological and emotional health might be affecting, some decisions he's making around his life and his self-management. So I think it would be important to, look at that. Certainly, running out of medications, we would be encouraging to go back and see his GP, and also maybe to discuss with his GP how he's feeling and how he's coping. So we would obviously be working on that relationship with Sam over the course of the cardiac rehab program, touching base with how he's feeling, how he's coping. Then also we would do a post-assessment screen again, PHQ-9, towards the at the end of the program, and that assesses the longer-term adjustment to the cardiac event and other life stressors affecting his mood. So we'd be looking at how he's been going over the course and how he's been adapting. Again, it could be, it would be a red flag maybe if he scored higher towards the end than what he did when he came in. We would be looking at the fact that he's had depression in the past, the fact that he's had a recent separation, has some family issues. So, what supports does he have at home around him who's helping him to cope? The fact, I think we mentioned that he was self-employed, so obviously worries there about going back to work. Financially as well, there could be issues. If he's self-employed and off on sick leave, and maybe financially the cost of the medications. So there's all of those things to look at as well.
I might just interrupt you for a sec then, Eve, and just ask the panel, is it recommended that depression screening happening at the pre-assessment at start of cardiac rehab and at the end? Because I know there's some cardiac rehab clinicians who are watching today. Is that current recommendation?
I can speak to the guidelines if you'd like.
That sounds great.
Well, the guidelines state in terms of timing that we screen as soon as possible close to the event, which really means in hospital, and then again at 2 to 3 months, which probably means sometime during cardiac rehab, or if they don't make it to cardiac rehab, when they go and see their GP or back to the cardiologist, and then repeat screenings yearly. My recommendation would be more than that, because I think we need to know that trajectory that we saw on those lines earlier, that it's really to do with whether symptoms are persisting or worsening, or whether they're getting better. If they're getting better, it's most likely the cardiac blues. If they're persisting or worsening, it's more likely depression, and we need to be very concerned. So I would say Neve is spot on with pre and post cardiac rehab, and if there's an inpatient screen that gives us a benchmark, even better. Yeah.
And if you're worried about a patient during the course of the cardiac rehabilitation because their screening test suggests that they might be depressive, what sort of resources do you have at your availability? What have you got to refer to or to go to?
So we obviously have the educational sessions that happen in the cardiac rehab program. So we have 2 educational sessions delivered by a health psychologist, one on managing emotions and the other one on normalising emotions and the other one on managing emotions. But we can refer to the health psychologist who's part of our team as well in our hospital, or we could refer on to the GP. Also talking to the patient about bringing that up with their GP is important.
Okay, and we have a health psychologist to talk to us about what would happen if you met Sam.
Well, I'm quite concerned about Sam in terms of his beliefs around his medication, what's going on in terms of whether this is passive or active avoidance of this medication, and what his understanding of his illness. So I'd be ready to explore the illness perceptions, really what Sam thought about his illness, how he thought it was treated, what was in his control. I'd also want to know more about how he's soothing himself. I'd be worried about, how much he might be drinking, how much he might be lying around in bed, and I'm worried about his missing family events. So there's enough in there for me to be concerned about him. I'd want to work very closely with his GP. I'd be initially getting him to put a bit more structure in his life, getting back to cardiac rehab, getting a bit more understanding around the medication and his illness perceptions, and developing some healthy methods of soothing his distress as well.
Okay. So just as the case study progresses, the cardiac rehabilitation nurse for Sam conducts the PHQ-2, which is the short form which was positive, and then goes on to conduct the PHQ-9. And everyone in the audience can see that on their slide. So Sam comes back with a moderately severe score on the PHQ-9, and the cardiac rehabilitation nurse arranges an appointment for Sam to see his GP for scripts that day, and then calls the GP, sharing the results of the PHQ-9, and then also talking a little bit about Sam's psychological health and what might be affecting his life and his self-management of his cardiac disease. So, Rosemary, is that an appropriate course of action for that cardiac rehab clinician to take?
Yeah, that's an excellent course of action, and the GPs are trained in this area. They're very good at managing and, you know, talking to patients around depression. They're getting better because of all the training, and it's quite appropriate.
Yeah. And it's worth mentioning that this is just a screening test, is that right?
Yeah, it's not a diagnosis.
Okay.
You don't have enough information to diagnose this client with depression, but you have enough to be concerned and to encourage them very strongly to attend their GP to discuss this.
Yeah. Do you feel the appropriate course of action, Barbara?
Yeah, I think the fact that he's now had, has he only had the single screen so far that's been high, or has he had 2 screens now?
If he was in Neve's program, he would have had 2, but he's only had 1
He's
in
only
the case
had
study.
1.
Yes.
I mean, because he's got a number of red flags, our health psychologist experts are very concerned about him, we know that. Putting that aside, if we got just a single screen that was very high, on the basis of the research, I'd be very concerned about a false positive. If that screen was done quite early, close to the event, we might be pathologising some symptoms that don't need to be pathologised. But in Sam's case, I think he's already lapsed from cardiac rehab. He's got a number of red flags. The screen's been done later. He's clearly showing some signs that he's not coping, so then the referral to the GP can only be a positive thing. And as Rosemary's talked about, collaborative care, which is also recommended in the NHF guidelines as well as one of the appropriate strategies for looking after people with depression. So as much correspondence between the different health professionals is obviously a positive thing. Okay. My only concern about the single screen is if it's too early on and we're sending everyone off to the health psychologist or the social worker or whoever based on a single screen, that could be a false positive.
Yeah, that is the normal adjustment process that people go through when they have a serious life-threatening, what they see as life-threatening event.
And when you, just defining the term false positive, that's someone who is screening positive for depression, but they don't actually have depression.
Yes, thank you for that. Yes,
just
it's
to
always
clarify
hard
for
to
the
get
audience.
that one right.
No.
So calling him a positive when he isn't, he's just scored high on a questionnaire. I think we need to differentiate between scoring high on a questionnaire and having a condition called X, in this case depression. Scoring high doesn't mean you've got a diagnosis, it's a score.
Yeah.
Okay.
If we had have done the PHQ-2 as an inpatient, would that help?
Definitely.
Yes.
Yes.
Yeah. So
It'd help us
highlighting-
identify the trajectory that he's on. And in this case of Sam, we would see that he's worsening over time, and that's a problem.
Yeah. Often you don't have access to that information in the cardiac rehab environment of what the hospital screening results were if there was one done.
Yes. So,
Highlighting again the
Communicating
importance
that.
of communication.
Yes.
And I suppose the other thing that might come up is that sometimes when people are feeling down or there is a lot of stigma around depression, that people might not always want that shared. Do you have any tips or hints on how we might be able to get around that as clinicians in the...
Yeah, there's stigma around depression and there's stigma around heart disease as well. Sometimes I've encouraged patients to actually take their PHQ score to their doctor, to their GP, to discuss it, to say, look, they gave me this and I filled it in and it's showing that, you know, maybe I'm a bit upset at the moment.
So putting it back in their hands.
Putting it back in their hands. It's and talking to them also about that, you know, this might be temporary or it might keep going. So be prepared for, if it is, that's becomes a very important thing to get managed and manage well.
Yep.
Excellent. I think that's really clear and we've highlighted the distinction between the cardiac blues and depression and the role of the clinician in exploring this. And I just might take some questions from the audience.
Yep.
So Shioko is a physiotherapist at Monash Health and she's asking, With so many patients experiencing these emotional events, are you aware of any outpatient or support groups available for them to access on discharge? Ones that clinicians can refer to?
I think your cardiac rehab is your absolute best support group. There's so much patients benefit from being in the same boat. They talk about, I'm so relieved to have got here. I don't have to explain my condition, and we're all in the same boat.
Yep.
That is your support group.
And I suppose one of the difficulties about, say, referring off to someone in the community is, particularly if they wanted access to Medicare funding, there has to be a mental health plan done, and that often has to be a diagnosis attached to that. Is that right? Like, would the cardiac blues be something where someone would qualify to have a mental health?
It would depend.
Okay.
It would depend. It may well be if they're showing symptoms of anxiety and depression, but I really, seeing patients with the cardiac blues, I'd probably only see them once and just reinforce the supports they get, normalise the fact that they've got this distress and reassure them that this will probably get better. But for patients who I see with depression, they will need to see me more than once, definitely.
Okay.
And for those with depression, not the cardiac blues, once they get to cardiac rehab and the correspondence starts with the GP and then referrals start to the health psychologist or a clinical psychologist, whoever it might be, then that depression will be managed extremely well beyond cardiac rehab. So cardiac rehab is obviously the best first starting point, and then the management can occur after that. Because we do, as much as we're saying reassure if it's the cardiac blues, depression is a very serious and debilitating condition. It has very dire consequences both for the person's quality of life and their experience of life, their ability to live their life and manage, but also for their prognosis in terms of their cardiac health. Yes. So we do want it to be managed extremely well.
It's a life-threatening illness.
Yeah.
Can be.
Yeah.
Okay. Another question. So, this is a question from Tony Rowe, who's an occupational therapist. She asks, can you provide a time frame of persisting symptoms that should alert us that the cardiac blues has transitioned into a depression diagnosis?
Good question.
That is a good question.
An excellent question.
Our research, I'll answer from a research point of view, and then the clinicians can answer from their perspective. The research would show that the 2-month mark is about the crossing over point. So we should see at around the 2-month mark, which is during the time of cardiac rehab or in some people's case when they're seeing their GP, that will be when symptoms should start to resolve or fully resolve, or at least be on an improving trajectory. Or if we're going on to a worsening trajectory, we should see things start to cross over. So on that graph that we were showing earlier, the little mark there is sort of around the two-month mark. That's what the research demonstrates. That's where we see that change, but it can't be used in every case.
No, and your problem is, as you can see, the worsening and the improving are crossing over, and the score may well be the same around
Correct.
the 2-month mark.
Yeah.
So it's really being aware of that pattern and the trajectory and those red flags.
And that's again highlighting the importance of having a score or a screen that was done in hospital when Kym's seeing the person, so we know is the trajectory improving or worsening, as well as referring to the red flags. But it is a very good question. It's a tricky one to answer because grief is a process in and of itself. You can't say, oh, grieving takes 2 months and then it's finished.
Yeah.
For some people, that grief process, that normal grief process can be longer. And I think that's why it's so important to look at the trajectory. Are they at least improving and not getting worse?
Yeah, I'd agree with you there, Barb.
Great. We have a question from Rosemary, who's a cardiac rehabilitation nurse. She asks, due to the short stay of ACS patients, should the PHQ be done as an inpatient on the ward, or should it be done at cardiac rehabilitation? Kym, go for it.
Well, I think, again, getting back to the trajectories, the earlier, the better. And it's really just a baseline. When we do the PHQ2 in hospital, close to the event, it's just a baseline of which to look at down the track. And also it's good to educate the patients so they can do their own monitoring. Yeah.
Yep.
So that would be what I would think.
And we would follow up in cardiac rehab as well.
Yeah.
Yes.
Screening.
Definitely.
Yeah. And I think, the definition of screening is a test for every person, not just the ones that you select. So screening everyone, screening early, screening often. That's what I'd recommend.
That's the message.
Yeah, great. One of the other questions that was asked to me the other day when we said we're doing this webcast was someone said that if I was going for an elective procedure or I was going for heart surgery, is there anything that you would be able to do to emotionally or psychologically prepare yourself for what might be quite a challenging time with the cardiac blues and depression after my heart event?
I think personally, forewarned is forearmed. If you know that, hey, this isn't just about my physical health, but it is about my emotional recovery, I believe that that's helpful. For some people want to know a lot, and some people don't want to know too much. So being very careful that we don't give too much information for people who cope by blunting or avoiding too much information, but we give appropriate levels of information for people who want more. So being able to respond to questions and give people more, but also holding on, not having to give them everything. As a clinician helping people prior, it's really dose dependent. The information needs to be titrated up to what the patient's ready to take in.
Yeah, great. All right. So Barbara, just going to ask for you to give us a little bit of a summary of the key messages that we'd like to close today with. How would you summarise our conversation?
Wow, that is a big question. I think one of the key messages that we were hoping to help our listeners receive is that pretty much, and Kym has said it a few times, a heart event is not just a physical one, it's an emotional one as well. Almost everyone will have some sort of emotional reaction, although as I've heard Rosemary say, if they don't, that's totally fine. You don't need to make them have one.
It's not compulsory.
Not compulsory. The cardiac blues is normal. We need to, using the guide like we have here with On Track, normalise and reassure, and that makes patients and people feel like they're on track and they're going okay, they're ready, forewarned, forearmed, forewarned. But at the same time, knowing what depression is, they do look similar in terms of symptoms, so we need to use the red flags, the trajectories to help us identify someone who's more at risk of depression, not to say they necessarily will develop it, compared to someone who, if they don't have those red flags, they've got good supports, they haven't had a history of depression in the past or anxiety, they're pretty good with their health behaviours, they're well connected and so on, we can be less concerned about those ones. But still really, again, as Rosemary just said, screen everyone, screen all, screen early, screen often.
Okay.
And communicate with your other health professionals along the path for the patient.
So to make sure that screening is documented.
Yeah. I think, would you add anything further?
No, I think that's
summary?
perfect.
Okay.
Yep. We just wanted to talk briefly about some of the patient support resources that are available that you might be able to share with your patients. Both Kym, Barbara and Neve have referred to the patient brochure, and I'll let Barbara explain the patient brochure and the on-track conversation starter just quickly before we finish.
Well, the patient brochure and the on-track kind of go together. They're really doing everything we've explained. They're normalising. You use them with patients, whether it's in inpatient cardiac rehab, to normalise, reassure, but also alert patients to risks which you might see. And it's just an easy way of having a conversation that could be difficult but helping, as Kym said, to make it a little easier,
Yeah.
a little bit less daunting.
And these resources will be shared with everyone who's registered to watch the webcast afterwards, as well as the paper around the National Heart Foundation Cardiac Society consensus statement on screening and treatment of depression. And we'll also share some of the Australian Centre for Heart Health's publications in the follow-up email. I also wanted to mention that the Heart Foundation helpline is available to patients. It's free, it's manned by, and there's health professionals that at a free call patients can call and request information, support. These clinicians are trained in the cardiac blues and supporting patients after a heart event, and can certainly facilitate referrals. So the number's on the screen, and I'd certainly encourage you to let all your patients know the Heart Foundation helpline is available to support them. So we've done questions for the panel, and I have to apologise, we do still have some pending questions, but we've run out of time for today. You're welcome to email me, and I can pass on any questions that you might have to our panel members, and hopefully they'll get back to you. That sounds okay, doesn't it?
Yep.
Yes, excellent.
Perfect.
So other than that, I would encourage you please to complete the evaluation and let us know how you found the session. Otherwise, thank you very much. Thank you to the panel.
Thank you.
Thank you.
Thanks, Eugene.
Yep.